I'm Seth Lerner. I'm a urologic oncologist from Baylor College of Medicine, and I run our multidisciplinary clinical and translational research program in bladder cancer. And at this outstanding 10th International Congress in Urologic Oncology, I had a chance to talk about three topics. First, I talked about BCG unresponsive non-muscle invasive bladder cancer. This is a huge challenge for urologists to take care of. Our current standard of care for patients who have recurrent high-grade cancer after BCG, and that's usually induction plus at least 3 weeks of maintenance. The current standard of care is radical cystectomy, but as we know, that's a really morbid operation and has a significant but low mortality rate. And so we're really looking earnestly to find new drugs, new ways of treatment, and the US FDA has developed a registration pathway for single-arm trials, which has really led to an explosion of drugs, a variety of different approaches that are being used to treat these patients. For the practicing urologist, we have a number of options outside of a clinical trial. Valrubicin is FDA approved, but the results with that don't look as robust at 2 years as I think we'd like. You can use drugs like gemcitabine, docetaxel. You can use those two drugs in combination. That's kind of our current favorite. There's device-assisted therapy, which is designed to get mitomycin, for example, into the tissues. And then a variety of clinical trials are testing things like antibody-drug conjugates, replication-competent and deficient adenovirus. And then there's some novel drugs, and of course, the application of some of the new immunotherapy agents to this disease state. So it's really exciting, some good initial data, and I think over the next 3 to 5 years we'll have probably a couple or a few drugs approved for this very difficult to treat patient population. The second talk I gave was another challenge for all of us in the multidisciplinary community to understand some of the biologic differences and clinical differences in patients who have what's called variant histology. So pure urothelial will be the most common, probably about 85% of patients. But then urothelial can differentiate into adenocarcinoma, squamous cell carcinoma, and other variants like micropapillary or small cell. And those patients may respond differently to chemotherapy, immunotherapy, and we need expert geopathologists to be able to identify these variants accurately. So for the patient, say, who has a pure squamous or pure adeno, chemotherapy typically won't work in that patient population. We don't yet know about immunotherapy, so typically we'll go straight to surgery with a radical cystectomy. But say, for instance, patients with small cell neuroendocrine, we treat those a little bit differently with chemotherapy that's been used effectively in small cell of the lung, so that would be etoposide, cisplatin or carboplatin prior to definitive treatment. Patients with micropapillary disease have an aggressive phenotype and should be treated with conventional neoadjuvant chemotherapy if they're platinum eligible, and then cystectomy. And so we know a lot about this variant histology, and the other thing that we're learning about is some of the genomic features of this, and there's a particular expression phenotype called, or subtype called basal squamous. So these are patients that have squamous histology. They're more frequently women, and they seem to maybe respond better to chemotherapy and maybe to immunotherapy. So we may be able to begin to tease out some of the molecular alterations and more of a personalized medicine approach for patients with variant histology. And then my last talk is about radical cystectomy and some of the quality metrics around that, and particular attention to the quality of the lymph node dissection. There's now been a reported trial out of Germany comparing extended versus standard, showing no difference. And we have a clinical trial, a slightly larger trial that we've done in the Southwest Oncology Group, which will report out probably in the next 12 to 18 months, that I think will guide urologists about the proper anatomic extent of a node dissection. And then, you know, as Joachim Belmont had talked about, the proper integration of neoadjuvant chemotherapy and adjuvant chemotherapy into the paradigm around radical cystectomy and predictors of response to that, and who's most likely to benefit from the neoadjuvant chemotherapy approach. And then we are getting much better at reducing the morbidity using enhanced recovery after surgery protocols. And there's been a lot of attention paid to so-called prehabilitation, kind of getting the patient ready like they would for a marathon, paying attention to their nutrition, using drugs that block the peripheral mu opioid receptors to enhance recovery of bowel function. And so we're getting better at this operation and getting people through the recovery so that they can derive the benefit of it. So I really, again, thank you very much for the invitation. It's been a lot of fun to be here.